Hello, my name is Mounzer Agha. I'm from the University of Pittsburgh Medical Center, and it is my pleasure to present to you our data on the cilta-cel CAR T-cell infusion in patients with progressive multiple myeloma following 1 to 3 lines of therapy. This is a multi-cohort study. It's called the CARTITUDE-2, and it is basically aimed at taking the CARTITUDE study the cilta-cel into earlier line of therapy. So in the CARTITUDE-1, which has already been extensively published, the patient has received unlimited number of prior lines of therapy. In this particular study, we are talking about Cohort A, and patient in this cohort has received up to 3 lines of therapy, but they must be lenalidomide refractory. Just to refresh everyone's memory, the cilta-cel is a CAR T-cell therapy that expresses 2 BCMA targeting single domain antibodies, which is designed to confer avidity. Cohort A, as I just mentioned, is one of the multiple cohorts in CARTITUDE-2, and patients will have received up to 3 lines of therapy, but they must be lenalidomide refractory. The patient will enroll in the study, they will undergo apheresis, and if the patient has a significant tumor burden, bridging therapy is allowed, and I will discuss why that in a couple of minutes. Patient will then undergo lymphodepletion therapy, followed by the cilta-cel infusion with a target cell dose of 0.75 times 10 to the 6 of CAR T therapy per kilogram. And the primary objective of the study was the MRD negativity to the 10 to the minus 5th power. And other secondary objective was the overall response rate, duration of a response, the time and duration of MRD negativity, and of course, the adverse events. The patient characteristic, as I mentioned, they would have received up to 3 lines of therapy. The patient who had high-risk cytogenetic constituted 35% of the patient, including 17p deletion and translocation 14 and 16. 85% of the patient would have received the prior autologous stem cell transplantation. 65% of the patient were triple exposed, and 40% were refractory. So even though this patient population included up to 3 lines, but they had a fairly refractory disease. And you can see 40% were refractory to bortezomib, 10% refractory to carfilzomib, and 60% were refractory to daratumumab. In all, 95% of the patients were actually refractory to the last line of therapy. Despite that, as you can see in this slide, the overall response and MRD negativity, the overall response rate was 95%. With 75% complete remission and 45% stringent complete remission. The median time to first response was very rapid, 1 month, and the median time to complete remission or better was 1.9 months. At the time of the data cutoff, all patients with MRD evaluable sample to the 10 to the minus 5th threshold were MRD negative. As you can see from this slide, the duration of the response is still ongoing. The responses continue to deepen with time. There has been no progression of disease at 5.8 months with the data cutoff. You can see the line here at the 9 months. This is where we expect the response to be at its maximum, which is what we've seen in the CARTITUDE-1. So obviously the responses are still ongoing and continue to deepen with time. The safety was fairly manageable. The majority of the side effects that were non-hematologic were quite mild, and grade 3 and 4 toxicity was quite uncommon. The majority of the adverse hematologic events included neutropenia, thrombocytopenia, and anemia. However, the grade 3 and 4 toxicity has resolved in the majority of patients by day 60. As you can see, the incidence of prolonged grade 3-4 cytopenia beyond 60 days was only 25% for neutropenia, 0 for thrombocytopenia, and 45% for lymphopenia. The most significant side effect and safety profile of any CAR T therapy is the CRS and neurotoxicity. 85% of patients experienced CRS with a median time of onset of 7 days, and this is delayed compared to other CAR T cell therapy. And the duration of the CRS was 3.5 days. It is important to note that the majority of the CRS were grade 1 and 2, only 5% had a grade 3 and 5% had grade 4. The CRS resolved or recovered in 94% of the patient by the time of the data cut. The neurotoxicity was encountered, the ICANS encountered in 15% of the patient with a median onset of 8 days and a duration of about 2 days. All ICANS were grade 1 to 2. There were no cases of movement and neurocognitive treatment emergent adverse events. There was one death related to COVID-19, which was assessed as treatment related. We identified that movement and neurocognitive treatment emergent adverse events are related to certain risk factors, 2 or more of the following: high tumor burden, a grade 2 CRS, and ICANS, as well as high CAR T cell expansion and persistence. And because of that, we implemented mitigation strategy that allowed enhanced bridging therapy to reduce the tumor burden, early and aggressive treatment of CRS and ICANS, and we implemented handwriting assessment and extended monitoring to alert us of the emergent ICANS. By doing that, more than 100 additional patients have been dosed, and the incidence of the movement and neurocognitive adverse event has been very low. So in summary, we show now that a simple infusion of cilta-cel has led to a deep and early response of patient multiple myeloma who have received up to 3 lines of therapy and were lenalidomide refractory. 75% of the patients achieved complete remission and or better. Responses continue to deepen with time, and we have obviously an ongoing follow-up. The side effect and safety profile was quite manageable. The CRS was mainly grade 1 to 2. There were no incidents of movement or neurocognitive adverse events. Because of that, cilta-cel is now being evaluated in the phase 3 CARTITUDE-4 in patients with 1 to 3 prior line of therapy compared to the daratumumab, pomalidomide, dex, or pomalidomide, bortezomib, and dex. And I'd like to thank my colleagues, the patient participating in studies, and all the physicians and nurses and the data coordinator who helped make this materialize. And thank you for your attention.